Hello dear colleagues, how are you doing today? I hope you are doing well. Today we are going to talk about Pityriasis Rosea. Definition: Pityriasis Rosea. Pityriasis means brand-like scale and rosea means rose-colored, is an acute self-limiting inflammatory dermatosis that may be caused by human herpes viruses 6 and 7. It is characterized clinically by oval, minimally elevated scaling patches, papules, and plaques that are located mainly on the trunk. Pityriasis rosea, oval pink patches with delicate scaling near border. Incidence: the incidence of Pityriasis rosea varies by population and study setting. In a population-based study from Rochester, Minnesota, the average annual incidence was 172.2 per 100,000 person years, with a slightly higher rate in females and a predominance in individuals aged 10 to 35 years. The disease occurs with some seasonal variations being least common during the summer months. History: characteristically, the generalized eruption is preceded by a single lesion called the Herald patch. This is frequently misdiagnosed as ringworm. The Herald patch is followed after several days to weeks by the generalized rash. The patient usually feels well. Itching is often present and ranged in severity from mild to moderate. Physical examination: the Herald patch, the largest of the lesions, range from 2 to 5 cm. The multiple lesions that follow resemble the Herald patch but are smaller. They are atypical, tannish pink or salmon-colored, round to oval, and surmounted by a delicate scale, which in the major lesions is located near the border. Typically, oval lesions on the neck and trunk follow the skin cleavage lines in a pattern that, with imagination, has been linked to that of a Christmas tree. The rash is distributed mainly on the trunk and neck and sometimes on the proximal extremities. In children, the face may also be affected. In addition, in children, papule or vesicular variants of the disease can occur. Oral lesions, although not prominent, have been described and range from pink macules to hemorrhagic puncture to small ulcerations. Pityriasis rosea. In A, we can see distribution has been linked to that of a Christmas tree, and in B, we can see Herald patch. Differential diagnosis. Although the diagnosis of Pityriasis rosea is usually straightforward, sometimes the disorders must be considered in the differential diagnosis. In tinea corporis, patients usually have only a few lesions. If doubt exists, however, a potassium hydroxide preparation should be done. The explosive onset of the small lesions of guttate psoriasis distributed mainly on the trunk can be confused with Pityriasis rosea. However, the scale in psoriasis is thicker and more silvery, and the course is more prolonged. Uncommonly generalized lichen planus can resemble Pityriasis rosea. Pityriasis lichenoides chronica is an uncommon disorder in which the lesions may resemble those of Pityriasis rosea, but as the name implies, are chronic rather than transient. Drug eruptions should be considered in any patients with acute generalized dermatosis. Usually, however, a drug eruption is more brightly red, more confluent, less scaling, and itchier than Pityriasis rosea. The most important diagnosis to consider in the differential is secondary syphilis, particularly if the eruption is atypical. For example, if the patient has no Herald patch, if the distal extremities, particularly the palms and soles, are involved, or if the patient is systemically ill. In all cases of atypical Pityriasis rosea, a serologic test for syphilis should be ordered. The conclusion of differential diagnosis of Pityriasis rosea include tinea corporis, guttate psoriasis, lichen planus, Pityriasis lichenoide chronica, drug eruption, and secondary syphilis. Note: for patients with atypical Pityriasis rosea, a serologic test for syphilis must be performed to rule out a secondary syphilis. Laboratory and biopsy. The diagnosis is made based on the characteristic history and physical findings. Skin biopsy is non-specific and rarely indicated. If it is performed, the findings will include mild hyperkeratosis with focal parakeratosis, minimal acanthosis with focal spongiosis, and a moderate dermal inflammatory infiltrate with a few of the cells migrating into their epidermis. Therapy. Treatment is usually not necessary for this self-limiting disease. Occasionally, antihistamines are needed for pruritus and moisturizing creams for the dry scaling that occurs as the lesions evolve. UV light therapy, UVB, acyclovir, or erythromycin appears to accelerate resolution, but these are usually not needed. The conclusion of therapy for Pityriasis Rosea: initial therapy. No need therapy unless the patient is symptomatic. An alternative therapies include UV light, acyclovir 400 to 800 mg 5 times a day for 1 week, erythromycin 500 mg BID for 2 weeks. Course and complications. The disease involves spontaneously in a time course ranging from 2 weeks to 2 months, with an average time of approximately 6 weeks. It recurs in only approximately 2% of patients. No complications occur except for occasional post-inflammatory hypopigmentation or hyperpigmentation, which resolves slowly over time, often months. Note: Pityriasis rosea clears spontaneously within 2 months. Pathogenesis. The rash appears to be mediated by a cellular type 4 immune reaction. A possible viral trigger, human herpes viruses 6 and 7, has been implicated. However, the disease does not occur endemically, and its occurrence in household contacts is uncommon. Clinical case: a 21-year-old woman presents with a 2-week history of a generalized skin rash. 1 week before the widespread eruption, she noticed a single large oval pink patch on her chest that slowly enlarged and developed fine peripheral scaling. A few days later, multiple smaller oval lesions appeared on her trunk and proximal arms. On examination, there are numerous oval salmon-colored macules and patches with colored scaling oriented along the lines of cleavage, producing a Christmas tree pattern on the back. The rash is mildly pruritic. She has no fever, no mucosal lesions, no palm or sole involvement, and no lymphadenopathy. She reports a recent mild upper respiratory infection. What is the most likely diagnosis? A. Tinea corporis. B. Guttate psoriasis. C. Lichen planus. D. Secondary syphilis, and E. Pityriasis rosea. According to our explanations, the correct answer is E, or Pityriasis rosea. Key diagnostic clues for Pityriasis rosea: Herald patch preceding the eruption, secondary generalized eruption, colorate scaling, Christmas tree distribution, truncal predominance, mild pruritus, self-limited course, and recent viral prodrome are all key diagnostic clues for Pityriasis rosea. While the others are unlikely, tinea corporis usually present as annular lesions with active raised borders and central clearing with a positive potassium hydroxide test. Guttate psoriasis is a chronic persistent smallpox without Herald patch or self-resolution. Lichen planus is a violaceous polygonal papules with Wickham styria, and mucosal involvement is very common in lichen planus. And secondary syphilis usually the papules are present on palm and sole, or we have usually palm and sole involvement. Mucous patches, lymphadenopathy, and systemic symptoms are present in secondary syphilis, and a positive serology test is important in secondary syphilis. Okay, this was an explanation about Pityriasis rosea. Thank you for your attention.